Good afternoon, everybody. Hello, my name is Sarah Russell and I'm Head of Research at Hospice UK, and it's really lovely to see all of you here today. I hope you're all here for our Frailty session, which I think led on really nicely from Professor Irene Higginson's session this morning, and it really made me think, and it also made me really glad that we have our three speakers today to talk about it. But before we start, just to remind everybody that all our presentations will be up on our website after the conference. Don't forget to visit the exhibition and the displayed posters, and also their oral poster showcase on Friday afternoon. This session really came about because we were really considering about with frailty. So should hospices, should we, could we, or would we be involved in people living and dying with frailty? And so I'm really pleased to be able to introduce our three speakers, who all of them are going to do a presentation for you. And then what we wanted to do for the last bit of the session is to open up the floor for discussion and thoughts from you. So what I'm really asking is, while you are listening to Caroline and Sam and Emma, to think about, what observations do you want to share with the rest of the group here? Or is there a question that you want to ask? Because one of the things that I am really impressed with in the displayed posters is the depth of thinking and the breadth of services that are going on for people which are not the traditional population of cancer patients. So I just really want to introduce everybody, and then we'll move on to Caroline. So our first speaker will be Dr. Caroline Nicholson. I think I want to be Caroline when I grow up, because she is a senior clinical lecturer at the Florence Nightingale Faculty of Nursing and Midwifery and at King's and St Christopher's Hospice. She's just completed her postdoctoral fellowship at the National Institute of Health Research and has tested an intervention to improve care of people living with frailty. And she's really focusing on how people their capacities and the frailties of living in old age. And I think that what Caroline will give us is a really good working insight of research, of real-world care for people with frailty. I'm also delighted that we've got Professor Sam Ahmedzai with us today. So many of you will already know Sam from all of his work at NICE and the NICE guidelines, but also his work in the National Institute for Health Research and National Cancer Research Institute. And he is an emeritus professor at the University of Sheffield. And I think what's interesting about Sam is that he's been a consultant physician in palliative medicine in both hospital and hospice setting for over 30 years. And one of the things I'm particularly interested in is his thoughts about where frailty sits within the research agenda as well. And then finally, we have Emma Hodges. Emma Hodges is the chief exec at St Giles Hospice. And although Emma's professional background is in human resources, I think what we're finding out and what we're seeing in St Giles, and as I know in other hospices as well, is about how we are designing and delivering new services in new ways with new partnerships and new collaborations. And Emma's going to particularly talk about their service really relating to frailty. So I'm going to invite Caroline to start off with, and that would be wonderful. Thank you, Caroline.
Well, good afternoon, and just to start by saying that I'm a palliative care nurse by training, but have spent the last sort of 12 to 15 years working particularly with older people outside of specialist palliative care. So coming back to St Christopher's and coming to a Hospice UK conference is a little bit like coming home for me, having been on the outside. But I'm hoping that some of what I've learnt and am questioning myself might be useful to you in your places of work, but also to us as a sector and as a service leader as we move forward into, I think, what Irene really very clearly showed us, exciting but challenging waters. So my job really is to start the conversation this afternoon. And I'm going to do that by showing you some questions that matter to me. So, frailty in old age, what does it mean? And does it mean different things to different people? Why does frailty matter to palliative care? And that will probably be quite short, given the fact that I hope from this morning we've got a view about that. Where are the challenges and opportunities for palliative care? And how do we become age-attuned in the hospice sector? Now, the word age-attuned comes from Professor Knight, who's a geriatrician, and he talks about the fact that actually all our services now need to be age-attuned. That it's a great cause for celebration that we will live into late old age, most of us, and yet our services don't do that generally very well. And then this quote by Atal Gawande, which for me, I think has been something I've come back to again and again, which is the issue about what is aging, which is the bit that we can manage and be involved with, but that have we medicalized aging? And is that experiment now failing? So I hope as I talk, there will be more questions for you than answers, and that together we will stimulate more conversation. So what do we mean by frailty? Well, professionally, what we mean by frailty is a discrete medical syndrome relating to old age, which is different from how sometimes people use the term frailty in general conversation. So when I started in palliative care, we used to talk about people being poorly. And in a way, frailty has taken some of that language. We talk about people being frail. But what I want to really talk about this afternoon is the medical syndrome of frailty, because I think it helps us to begin to understand and specify what type of older people we as a hospice sector and a palliative care sector can become involved with. So this is Andrew Clegg et al. In The Lancet, and I won't read that to you, but essentially what it tells us is that frailty, I don't know if I did something then, is really about low reserve and low resilience. And I particularly like this diagram because it helps me to understand the distinction between somebody who's frail and somebody who's not. So what happens in frailty is that your core ability to bounce back from relatively minor, trivial things like, for example, a urinary tract infection or a fall becomes hugely compromised. And what I like about this diagram is it shows you quite nicely, if my pointer's working, that what happens is that a minor illness, you go down much further and you don't come back up quite so quickly or often to quite the same extent. So when you begin to think clinically of the sort of people that you see who may be frail, this is why a minor illness may actually be a dying event. And that's hugely challenging for us because that's not the paradigm in which we've been working. So just a little bit of facts about frailty. It's common. Frailty is not the same as aging, but it is the case that the older you become, the more likely you are to be frail. And the question which I wrestle with is, at what point do those coalesce? And what's about frailty and what's about becoming old? And nobody's been able to answer that for me yet. It's progressive, and you'll see that progressiveness is one of the things that's both useful and very challenging for us. That someone can live with severe frailty from between 5 to 15 years. So the question is, where's the sweet spot where palliative care might be useful to that person? It's episodic, and typically, and I say typically because there is actually now a characteristic of frailty and obesity, but actually typically a person who's frail is often very thin, sarcopenia, muscle wasting, exhausted and low in mood. And this is a word cloud that professionals, when I did some stuff on frailty, we put together. And I guess what that leaves me with is, who wants to be labelled frail? And it's not at all surprising that this definition and how we talk about frailty as professionals is not one that's owned very much by the people that we're trying to help. I often say that there are a few self-empowering narratives of frailty. What I want to do is just give you a different definition of frailty, and this comes from my PhD work, where I followed people who were living with frailty at home for 17 months. And the youngest person in the study was 86, and the eldest was 101. So I think that helps you to understand that chronologically, frailty is very diverse, and that chronologically may not be the best way to be thinking about this group of patients. But this is how they talked about their experience of being frail. They felt that they were seeing life in a different way, not just physically, but in their whole manner of how they viewed the world. But my confidence in life in general has gone, you know, because you can't do things. I'm frightened to a certain extent, but it might be the wrong word, but in a general sense, the way the world is going, everything. I haven't got the confidence anymore. So this physical biomedical syndrome of frailty for this group of patients isn't talked about in that way. What it's talked about is not knowing who they are and where they are in the world. And what people talked a lot about in my study was the hatred of being looked at as though they were different, because they're the same on the inside. So what I talk about is that frailty is a state of imbalance where people are constantly doing at least 3 activities, if you want to call them that. The first is experiencing huge loss. And that's the accumulated losses in the biopsychosocial domain, not just physical loss. And that loss, for most people in my study, was talked about in terms of a lack of a future, but not talked about in the professional language that we might talk about in terms of dying. And this is actually the wife of a gentleman in my study. And we were having a conversation, and then he went out to use the facilities. And as he went out, she leaned into me and said this, and then he doesn't seem to be so strong. Once we nearly got as far as the pillar box on a walk, but now, I don't know, he doesn't want to go as far as that. I'm just terrified he's going to die. And the moment he came back in the room, that conversation stopped. So there is a huge amount of loss in frailty. And I do think, for most people, there's a much more conscious understanding that they're living with what I call finitude, a limited future. Now, the challenge for us as palliative carers, that may not necessarily relate directly to talking about dying. Lots of people in this study spent a huge amount of their time in what I call retaining connections and anchorage to their normal patterns of working. And that means that their worlds can become very small and it very much ritualized. And of course, what happens when carers, either social or professional health carers, get involved is that we tend to cut across behaviours and ways that people do things because we want to do it as quickly as possible. And paradoxically, that makes people feel more frail. And finally, what was extraordinary for me in this study was to bear witness to a huge amount of capacity that people had in dealing and managing the everyday with their frailty. And for some people, they were able to create new connections. So there's a lady in my study who used to love gardening. She's now completely bedbound and cannot get out into the garden. But she's taught her carers how to sow tomato seeds. To some extent, she's become a head gardener. And so what I'm interested in is, what are the resiliences and the capacities that allow people to keep finding meaning when so much of our culture and perhaps ourselves thinks that to be totally dependent like that lady, she'd have no sense of self. And yet she did. She was extraordinary. So for me, there's a huge paradox. No one refers to themselves as frail, often, other than professionals. And that actually older people with frailty are the survivors, outliving the majority of their cohort. And I just want to, before we go on to talk about the challenges and opportunities of frailty, just to reiterate that and underline it, that there is considerable capacity and capability in older people with frailty, and part of, I think, what we have to offer in palliative care is to keep that in the forefront, when so often, because our work in the NHS is very time limited, it's very difficult to keep that at the front. So this is my alternative definition, which you can read more about in one of my papers. I call it a state of liminality, betwixt and between living and dying. And the reason that that might be useful to have and to think about is that when we're dealing with and working with people with frailty, we have to take account as much of the living as we do of the dying. So why does it matter to palliative care? Well, we have a rapidly aging population. Older people are our super users. And you will have seen that data this morning from Irene. And yet we know that generally older people, particularly older people who haven't got a defined diagnosis, are the highest users of our services, yet have the most poor experience. 75% of all hospital deaths are in people aged over 65. They're less likely to be seen by specialist palliative care, and their relatives are less likely to even know what an older person's preferred place of care is. So I'm pretty convinced that we have a role to play. I think frailty is important because it helps us to understand the specificity of older people who are getting to the point where some form of palliative care might be useful. So we know that people with severe frailty, as defined on the Electronic Frailty Index, and I can talk about that later, are 5 times more likely to be dead in a year than another older person without frailty. So that begins to help us to characterize this huge group and population to say who might be the type of person that we would need to see or become involved in. I know that this morning Irene talked a lot about multiple morbidity. And then the new NICE guidelines, which came out at the end of last year on multiple morbidity, talk about frailty as a syndrome that fits within multiple morbidity and is currently being seen very much as a signpost to help us to understand this very complex and very under-researched part of disease management. So I think for me, frailty offers us a huge amount. But what are the challenges? Apologies for the graininess of this photo, but this is a gentleman from my study. One of the things that I asked people to do was to represent themselves to me in the way they wanted them to be seen if I was going to talk in conferences, and this was the photo that he gave me. This is Eli, who started his life in India and came over to this country aged 54. And his early career was on the Indian Peninsula Railways. And a lot of our conversation, or certainly our early conversation, was around those amazing times for him. So we met about 3 or 4 times over the course of the study. And what I hope you'll get from hearing a little bit of his story is a little bit about the identity work that he was doing, but also how his sense of self was really challenged by the erosion and dependency as his frailty became worse. So in his first interview, bearing in mind he was 101 when I first met him, he was extremely articulate and extremely active. And he said this: "People get tired, but not for me. I don't end, just I don't retire. One thing old people here in this England, they have done one job and they retire. I have retired, T-Y-R-E-D, if you follow the language." And he talked a lot about that sense of finding new things, keeping retiring his bike, keeping going. This is part of our story that we constructed together 11 months on. I can't recognise because my hearing is not good. My sight is also, I can't recognise. My mind is working constantly. Why is this happening? My mind is wanting, but my body is not able. And in the last 6 months of data collection, I saw him on a number of occasions, and he repeated constantly a story of becoming unwell, phoning the GP sending him into A&E, and the doctors in an A&E basically sending him home again. This is the doctor in A&E. At 8 a.m. a doctor comes, PM, sorry. "What's your age? Why have you come here? You should go home." "You go." "I don't know what hospital means when you take the old there," is his response. "How am I supposed to? Where should I go?" And it seems to me that his personal fragmentation is mirrored in the response of services who don't know what to do with him. In the end, because I know he wants to die at home, I ring the local specialist palliative care team, who declined to see him because he had no specialist needs. Their question to me was, "Would you be surprised if he was dead in a year?" And my response was, "I'm surprised he's still alive, but he is." Eventually, we mobilised a matron, modern matron, who was great and gave him equipment and some support. But actually, his dying, which was good at home, was not done by specialist palliative care or palliative care at all, but by a group of family and friends. But interestingly, in his notes, his death was described as sudden. So for me, his case has become a real sentinel case that I go back to about the challenges and the opportunities of frailty. And I guess one of the great challenges are the trajectories of dying are hugely unpredictable in this group of patients. You'll see on this diagram by Scott, Murray and Shake, this is the trajectory of dying in frailty. Now, if I was clever, what I'd want to do was to say that any of these could be a dying event. So actually, the trajectory is possibly more like organ failure. Because people live for a long time with prolonged decline, dying may not be engaged with. And I want to give a shout out for Sarah Combs, whose work on early intervention around advanced care planning. She's got a poster here, and I warmly suggest you go and see it. But the question is that so much of the focus often is on dying, and so much of the focus for this group is on living. So when I was doing an oak with a gentleman the other day, I said to him, "What's your goal of care?" And he said, "My goal is to keep on breathing." I thought, okay, that's probably not something that's in my gift, so let's think again. But it was in a moment where it struck me again that the language that we use and some of our instruments don't necessarily relate hugely well to this population. I think as I've engaged more and more in this work, one of the questions for me, and one of the questions that often people say to me, is this isn't about specialist palliative care. It's not our work. And I want to just gently challenge us, and I say us because I'm a specialist palliative care nurse by training, that actually if it's not our work, whose work is it? And that there's a huge tendency to split between the heroic and the stoic. So the work of persistently being there with somebody over time is very, very difficult. And that's the work that we give to people in care homes. And it's the work that we expect families and friends to do. We're very good at going in and being the A-team. And I say that as somebody who really got a lot out of that work, but I'm questioning myself now. I'm deliberately being provocative, so it seems to me that we need to see and think differently. Oh, I'm going to just really quickly go through. So I think the opportunities are to revalue living and dying, to remodel palliative care services. And that requires us to really begin to think about rehabilitation and living as well as dying. And this is the work that I was doing around trying to make it very clear that partners and experts in the room were carers and family. And a reorientation of palliative care, a move beyond disease to complexity, and the sea change work and the oak work that is coming out of the CSI is really important on that. I just want to finish with some of my thoughts to date. I think we need to understand and evidence the need much greater than we currently do. And what evidence we do have tends to be very much around the physical rather than the psychological, existential, and social domains of frailty. I think we need to be much more in partnership across health and social care and revaluing the communities in which people live. We need to think creatively about new and flexible services. I'm involved in a care coordination service, which I'd be delighted to talk to you about, which is working with GPs and district nurses and adding a little bit of palliative care every now and again. We've also heard about short burst specialist palliative care. What I do think we do very well is to help mediate people into a different reality. There's something about keeping death in the room and talking about it when people want to. I think we need to really revalue and get back some of the vision of the hospice movement, to revalue care and appreciate dependency and support much more those that we offer and give this incredibly difficult work to. If you want to talk about complex, I think trying to be and give quality care to somebody with advanced dementia, it doesn't get more complex than that. I think we need to do it with humility. Dying is messy and mysterious, and there are huge tensions, particularly in a life long lived, where a mother becomes a daughter, and a daughter, for example, becomes a mother. So I'm going to leave you with some questions that we might want to pick up later. Where are you in your organisation and yourselves engaging well with frailty? And how can you do more of that? What partnerships do we need to attend to? And how does your hospice and the services that you provide reflect the needs and the demographics of the community that you serve? And finally, are we changing as fast as the world around us? If you want to know more and this has excited your curiosity, this is a little bit of a plug. We've got a conference next June. I've got some flyers and I would be delighted to talk to you about it more. Thank you for your attention.
Thank you, Caroline. Now, I'm sure that lots of people have lots of thoughts and questions after that, so I'm going to ask you to hold those, write them down, and I'd like to invite Professor Sam Ahmedzai to kick off with the next bit of our session today.
Thank you, Sarah. Thanks for inviting me to take part in this session. And judging by the number of people here, I can see it's obviously something that is engaging the community here today. I was asked to speak about research in frailty, so I went back to my colleagues at the NIHR and the NCRI and sort of dug up what I can find about research. And so in 15 minutes, let me share what I know. Firstly, frailty is on the increase. I mean, thanks to Caroline, we've got a fantastic insight into what frailty means, both in terms of as a research construct, which I'll be addressing, but also from the human perspective as well. But looking at the numbers, there is an increasing amount of frailty in our society. This is a fairly recent publication, a cohort of 7,000 patients who were assessed over many years, over a 12-year period, mainly by their carers using proxy measures. And you can see in that time period, there was an increase in pain by 12%, an increase in depression being reported by 27% increase, but frailty increased by 39% in that 12-year period in that cohort of people. This is in the US. So it's something that's here, it's with us, and it's increasing. Now, I looked at what studies are going on in frailty in the UK, and so I went to the NIHR portfolio and other databases, clinicaltrials.gov, and I found that actually there's not that many studies going on right now. There's one open trial in cancer at the moment from Newcastle looking at assessment of frailty in elderly patients with advanced cancers. There are other open trials in King's and Derby and Birmingham looking at different aspects of frailty, measurement of frailty, assessment, but also looking at the impact of certain interventions such as vitamin D and resistance training. So those trials are happening right now. Maybe some of you are taking part in those. I mean, as researchers, not as participants. These are some studies which have recently been completed. For instance, there was a study on the effects of testosterone in frail elderly men. I'll come back to androgens later. That's from Manchester. An assessment of frailty in people with advanced hepatocellular cancers, and also a study in cardiac rehabilitation and how that addresses frailty issues as well. So these are studies which have recently been completed in the UK. And here's a few studies which are waiting in the wings now. They've been going through the process and they're ready to be launched. So 2 studies from Birmingham, one on keeping active in residential care, another one called seated physical activity in aging, and then another study I was interested in looking at fortified foods for older inpatients as well from Southampton. So there is a kind of a tranche of studies coming through, but not that much compared to the world and mostly the US literature, which I'll be quoting. Here's an interesting publication from a few years ago, actually from a cardiology journal, because frailty occurs in every medical area. It's not just to do with cancer, which is where I'm mostly working, but in every other area, particularly those with chronic disease and chronic organ failure as well. And this represents 2 models of how people end up with that frailty phenotype, how they end up looking and behaving as a frail person. And on the left, we've got the increased inflammation pathway through which also also there are the reduced androgens. That's where the testosterone comes in to replace androgens that all of us, males and females, are losing as we get older. So that's one pathway. There's another pathway to do with the chronic conditions that Caroline referred to, the chronic heart disease, the renal disease, where there's step-by-step organ failure, and also the kind of general dysfunction that happens as a kind of deep muscle deconditioning. So those two things move together. On the one hand, we've got inflammation and loss of muscle mass, sarcopenia, and on the other hand, we've got organs failing, and we end up with that frailty phenotype. And you can see in the middle, we've got things like slowness, weakness, shrinking of the body, inactivity, and exhaustion, which is what the frail person is experiencing. Now, interestingly, Caroline talked a lot about older people, and yes, frailty does affect mostly older people. But can I just warn you, we're creating a generation of younger people with frailty. At least in my area of cancer research, we know that many of the treatments we give for cancer, chemotherapy, some of the hormone interventions, actually are making people into a frail phenotype before their time, younger people. And we now recognize something called sarcopenic obesity, where we actually have somebody at the end of treatment, we've shown this in multiple myeloma, that will actually have outwardly an obese body shape. They will be, less fit because of that. But actually, if you look inside, they've lost muscle. So they're sarcopenic, but in an obese body. This kind of person will have metabolic syndrome, lots of other these pathways going to a frail phenotype long before they're very, very old. Lots of different ways that we can measure frailty. We can look at their measurements, and there are qualitative and quantitative measures of slowness, weakness, low physical activity, how you measure exhaustion, how you measure even the shrinking of the body as well. And also people have tried to look at biomarkers as well, which I'll touch on later. So there's no shortage of ways that we can look at how frailty is affecting the people that we're concerned about. But we also need the qualitative approach as well. Now, here's one measure. This was a study actually looking at biomarkers. They're trying to find a biomarker for frailty, but while they were doing it, they assessed a few other things, and they assessed the time spent sitting in a group of older people, 162 people over the age of 60. And they found that a very strong independent marker for the prognostic sign for frailty was how long people spent sitting. So men, if you're over 60, spend more than 257 minutes a day sitting, or women, if you spend more than 330 minutes a day sitting, that's a sign that you will be moving, it could be moving into a frail pathway. So women, I don't know why women get this extra time, an extra 100 minutes or so. Here's a systematic review looking at the interventions such as exercise. Now, we know that one of the big components of frailty is loss of muscle tone, loss of muscle mass, sarcopenia, loss of muscle tone, deconditioning. It comes from different roots. But what can we do about it? So here's a study, a systematic review, looking at originally 507 articles, but only narrowed down to 9 trials, because when you look at quality studies, there's not very many. But they found, for instance, there were 6 multi-component exercise studies, 1 physical comprehensive training program, and 2 strength training exercise programs. And the results of these, when they pulled them together, showed that 3 out of the 5 trials which looked at reduction in falls showed that exercise improved. 4 out of 6 trials showed that mobility could be improved. 1 out of 3 trials showed that balance could be improved. And that's really important, because if you lose your balance, you fall, and if you've got osteoporosis, you're then into a very dangerous pathway with fractures. 2 out of 4 studies improved functional ability. 5 out of 7 improved muscle strength, objective muscle strength improvement, and 2 out of 3 improved body composition as well. But because of the different types of interventions, the different types of exercise programs, they weren't able to suggest an optimal program. So more work needs to be done to say, with that knowledge, with all these different kinds of interventions, what can we do to implement so that we can actually help people prevent that frailty pathway? We've heard about obesity. Obesity causes frailty. Systematic review again with 21 trials showed that there was a consistent beneficial effect of lifestyle changes any kind of lifestyle change, on physical functioning, but weight loss was actually more powerful than physical exercise alone. So just reducing weight in obese people is a very powerful thing you can do to prevent later frailty, even more than getting them to do exercise. Obviously, if you combine the two, that's the best of all. And interestingly, the weight loss programs actually had a reduction in the inflammatory biomarkers, if you're interested in those, whereas exercise didn't. Now, I'll come back to those markers later on, but again, there's an objective measure that you can see of what is weight loss doing for the benefit of the person there. So are biomarkers helpful? Well, I like to think so, because we're always looking for biomarkers, at least in the cancer and in other disease areas. We're looking for that because we know that the human body is a very complex organism, and if we just study the whole organism, we learn a lot about the experience of that organism, but very little about the mechanisms as what are going on to lead to that experience. So that's why we look for biomarkers. And there is increasing evidence that inflammation, systemic inflammation in the body, which goes along with cancer, with coronary heart disease, with cardiac failure, with COPD. So it's a feature, systemic inflammation is a feature of many chronic conditions that can lead to objective measures of frailty. So one of the easiest measures we've got, markers, is C-reactive protein. It's a very easy blood test. It's cheap. It's done not routinely, but it's fairly easy to do. So studies have focused on CRP, C-reactive protein. And there is an association of a raised level of CRP with frailty, but it's not consistent. Not consistent enough to say that if somebody has got a raised CRP and they haven't got an acute sepsis, then, oh, it looks like they're going into frailty. It's not as clear-cut as that. There are other factors. For instance, gender, sex has a role. Ethnicity has a role, and that may be because different ethnic groups express these biomarkers in different ways as well. So the search is still on. We're looking for objective measures. We'll always do that, but right now we can't rely on those. What about the impact of frailty and end of life? Because this is Hospice UK, we need to look at people coming towards the end of life, if not actually dying, but preparing for that phase. This is, again, a cohort study looking at a group of patients over 65 after an acute hospital admission. So 306 people, and they were followed up over 6 years. They all received a comprehensive geriatric assessment, which is one of the measures you can use to assess frailty and other things that are happening to people at that stage of life. The people with frailty had the highest rate of medical conditions. Frail patients had the lowest expected mortality, but actually had the highest death rate. So if you ask people, maybe the surprise question, there's two people, there's a cancer patient, there's a frail patient, who do you think is going to die sooner? They thought it was the cancer patient. Actually, the frail patients were dying sooner than expected. And actually, there was poor evidence of advanced care planning in this population, considering that they were going to die in a very near future. I think it's something like only 45% of people in that study who were going to die in that period actually had an advanced care plan. So what about the impact of frailty at the end of life? This study looked at various parameters, a Dutch study, and they compared 3 groups: cancer patients, people who had end organ failure, and the frail group, which I've highlighted in blue. And as you can see there, only 40% of people were expected to die in the frail group, but actually 77% of them died. And it was the opposite for cancer. So we're misjudging the prognosis of people with frailty. And if you look at the consumption of hospital resources, inpatient, outpatient, etc., the frail people tend to get a very poor deal. They were not accessing hospital care. I mean, some people might be pleased with that in budgetary terms, but actually they were not getting the care they needed because they were clearly as ill as the cancer patients. And in terms of the restrictions of treatment, this is a kind of proxy for any kind of advanced care planning. What things would you not want to have done? The frail patients had the greatest number of restrictions, often imposed by healthcare professionals, not necessarily the frail people themselves. And finally, does frailty impact on carers? Here's a study looking at 9 studies, and they were looking not just at the patient's frailty, but the impact that it had on carers as well. And unfortunately, this was a systematic review. They were not able to elicit from that any clear signal. But clearly, it's kind of intuitive that there will be an impact on carers, but we can't say that from the current research. We need more research, not just in frailty, but also the impacts on the people, the family members and the carers of those as well. And finally, why wait till it's too late? Just like in other areas, we're saying, can we intervene earlier before the things that we're looking at become irreversible? We know this with cachexia. If we wait too late till people have got cachexia, we can hardly do anything about it. So we defined a group of people with pre-cachexia where we can intervene better. And now there's this concept of pre-frailty as well. We know the spirals that people go through, the physical changes, the psychological, the social changes which lead to frailty. Can we detect those earlier and actually prevent frailty? So prevention may be better than the interventions, which I've showed you. Some of them can work, but actually we may be better off intervening earlier on as well. So from hospice care point of view, because you're talking about patients with cancer and non-cancer, we need to be talking about looking at rehabilitation more and more, and that's really important that rehabilitation is on the agenda in hospice care, obviously end-of-life care as well. What I like to see in this conference is this great merging together of people who are interested in people at the very end of life, but also moving upstream as well. And I think that's my main message. Let's move upstream. Let's look at patients where we can actually do something to prevent some of the mishaps and some of the privations they experience at the very end of life by starting earlier on. And just a little plug, do come and see us at the NIHR stand, number 17. We do have chocolates there. Thank you.
Thank you. I don't know, thank you, Sam. I don't know about anyone else, but I'm just sitting here with a huge going, oh, thank goodness, look at all that wonderful research you've found for us. And I'm very grateful. Thank you. As well as the chocolates. I'd like to introduce Emma Hodges now, who's going to talk about the work they've been doing at St. Giles. So over to you, Emma.
Thank you. So just thinking about the subject of frailty and whose role is it, this sort of came along, various things were going on at the hospice. We were thinking about our 5-year strategy. I'm doing some work around dementia as part of my doctorate from an organisational perspective. And in the work that I was doing professionally for my doctorate and also with colleagues as we were exploring our strategy, the issue of who we cared for came up routinely. So we had to spend some time thinking about what can we do and who are we? So I would argue that to know whose job it is, we have to decide who and what we are. And that might be different for each individual hospice. So there's lots of definitions. So are we specialist palliative care providers? The concept of specialist and generalist, do we even know the difference between those now anyway? Are we end-of-life care providers and how do those fit together? Are we only palliative care providers at end of life? And that was starting to come out as a theme in some of the survey work that I've done for my doctorate. And are we community development organisations? And actually, we might be a combination of all of these things, but certainly internal colleagues were very confused about what we actually are as we've expanded services. And the how to decide who we care for is really difficult because, you know, we would all want to be able to provide care for everybody, but actually what can we afford? And can we really shift funding from the NHS to do more? I've been around the health sector now for a long time and funding does not shift between the acute sector and community services. And so we have to be realistic about those budgetary constraints. And can we really do more for less and maintain quality, really? And sometimes we're challenged by the platinum service that we're accused of providing sometimes by commissioners, and this potential, how do we redefine what we do and look for cost savings? And I'm sure we're all doing that anyway, but should we really move away from the high quality that we provide? Increasing demand and expectations, we've seen the numbers of people expecting and needing our care is exploding. And what's the right thing to do? And what of the issue of equity? So all of these concerns were sort of mulling around my mind
As then I was starting to do some early findings from my data collection. And I've put these as data comments because it's too early to say they're findings. I'm still very much in the data analysis phase. This question, these comments come out of a survey that was specifically related to dementia. So specifically looking at hospice's response to the challenge of dementia from an organisational perspective, not from a clinical perspective. And it was interesting because the majority of hospices were concerned about funding and capacity. 82% of those responded were not being asked by commissioners to do more, and particularly do more for people with dementia. Hospices were feeling that demand for existing services was a significant concern, concern about what the appropriate models were for a long-term trajectory disease. Lots of comments about the generalist specialist issue and the expectations of our workforce. And this has come out in themes in some of the interviews, and I don't think we should underestimate it. I've heard comments from team members that have come to do specialist palliative care and then are concerned that we have some CHC-funded beds that might be seeing less complex patients. Are they going to get the experience that they join the hospice for? And I heard about another hospice who had a comment about, well, we're just running a nursing home if we can't discharge these specialists, these CHC-funded people that are no longer complex and requiring specialist palliative care. Issues of professional identity and the acceptability of change to our workforce, I think, is a bigger issue, certainly one than I realised. What was interesting on the survey around dementia is most people were partially in. Most respondents were looking to do something around dementia. Very few were all in or all out, and there were a couple that were all out. And I suppose the relevance of this early thinking on the doctorate is that if this is relevant, if this is what people are saying and thinking about dementia, which is arguably recognised now as a palliative condition, Jenny van der Steen's work is very good at articulating the applicability of palliative care for people with dementia. Yet if this is such a challenge, then how does that then relate to frailty, where maybe we are arguing it's a palliative condition, but is it? And is that what we're saying? And what's the consequences of doing so? So moving on from the early thinking around the doctorate to our strategy, we rebranded, we launched a 5-year strategy, we had a new strapline, and we did some big sessions in April to introduce this to our wider local audience. And it's landed very well. It's been a really positive experience, but we had to define what we are. And as I say, our internal colleagues were very confused. I came across in my literature review these 4 categories of patients approaching end of life, and it comes from a document by the GMC, Treatment and Care Towards End of Life. Now, obviously what we've heard so far today is that categories are not particularly helpful, definitions aren't particularly helpful, but it was a starting point. And it was a point that when I was working through definitions for my literature review, I thought, you know what, actually I can use that to build a service model around. It gave me some context around the confusion as to the type of organisation we actually are. So I am going to cover these in each in order, just to talk through what we're doing for each of these categories. But before I do that, I want to talk about the safety net that we've put under our whole community, because for each of those categories, this safety net exists. So these services, our advice line, which is 24/7, the bereavement help points that we run in most of the towns within our patch now, which are run by trained volunteers, our children's bereavement service, Phoenix, the education work that we do, and community engagement is there for everybody, no matter what age, no matter what diagnosis, whether they're known to the hospice or not. A few years ago, if you were not known to the hospice, you would not have been able to access any of these services within our locality. So that's been quite a change for us. Community engagement work, and we're moving very much more into community development. We're very lucky that we have Staffordshire STP interested in a public health approach to end-of-life care. It's early days, they might lose interest, but I'm staying optimistic. So our community engagement work has really exploded. This is a map. You don't need to read the boxes. You can just see there are a lot of them. And it was about 4 years ago. It's got our old logo on. And I'll come back to this in the context of frailty, but this map has exploded since it was first drawn up. And this is what we mean by community engagement, connecting people within the communities, adding resilience, adding skills and development on issues to do with loss and end-of-life care. But as I say, I'll come back to a couple of examples on that in a moment. So the categories. Life-threatening acute conditions, sudden catastrophic events. So the issue of sudden death. For us as a hospice, we don't see these people. They're in an acute hospital. They're not the norm for us as a hospice, and we're not pretending to be able to see everybody in these end-of-life care categories. But we do have our advice line, and we have had people call it because somebody has died suddenly and they haven't known what to do. We have our bereavement help points that are not time-limited, that are free, and there's no waiting list. And our children's bereavement support has specifically supported quite a few children grieving due to a sudden death, including suicide. So that is our offer for that particular category of the 4 categories that the GMC refers to. This is existing conditions. There could be a sudden acute crisis. I know I'm here to talk about frailty, but this is the one I'm really excited about because as a category, I think this is where most of our innovation is coming. This is where we have the community safety net. We have intermittent support. We see that we won't case hold these individuals. They're more likely to come to us for short bursts of symptom management. They're more likely to have that lower level soft touch from the hospice in terms of self-management, symptom management approaches. We have a group for people with MS that actually funds itself because they make a donation, so it doesn't cost us anything. And they have created a support group. They have some conversations about particular topics when they need them. We have our virtual reality pain management app, which is downstairs. We have a pain management toolkit that we've used to start to support a wider group of people accessing support when they need to. Of course, some of these people are frail. These categories are not exclusive. We're looking to do more complex case reviews, working closely with primary care, and we do hospice at home for this category. This, I think, is really exciting. There's lots more we can do that will expand the numbers of people that we can see at a lower cost than traditional hospice services. This, of course, is the traditional hospice. The services that you would expect. We throw everything in the kitchen sink. We case hold these individuals. We don't discharge them back to the NHS unless they stabilise and move down a category. Should we be spending most of our money in this particular category? That's something we can debate. But this is what we continue to provide, but we're definitely doing it in a more cost-effective way than we were. We've redesigned our community palliative care nursing team, and there's a poster downstairs that talks about that work. So, frailty. Obviously, we've heard different definitions, and again, definitions can help or hinder. But for this category, we have a range of a service offer. We have our community safety net. That is completely charitably funded. We have arguably a little bit from the NHS when it comes to the advice line, but only through redesign, not specifically. We have nursing home support services. We have East Staffordshire is actually funded through Virgin Healthcare, and the CCG, as part of the STP programme, is now looking to roll that model across the rest of Staffordshire. So it looks like we're going to get some more funding for our nursing home support service, which is fantastic. Social care service, so domiciliary care, is privately funded. All of our dom care now is private. We couldn't provide the quality of employment and quality of care at the statutory social services tariff, so we've moved away from that. We have 6 continuing healthcare beds. They're separate to our specialist palliative care beds. This allows us to take people in that would otherwise be dying in hospital, who are not specialist palliative care, who are not complex, who may well be frail. And we have a range of wellbeing activities, and I'll give you a couple of examples of those in a moment. So on a good day, I think, do you know what, we are doing something for this group, and we're doing it in the way that we can afford to, and it's maybe not radical, and maybe there's more that we can do. And on a bad day, I think there's just so much more we should be doing, but we can't afford it. So our community safety net and compassionate community, specifically around frailty, we have a couple of examples. We have a wellbeing programme that we've run in partnership with Age UK out in Burton. We're about to do another project in Rugeley, elsewhere in Staffordshire. And that's very much about some seated exercise, talks from various other agencies. We've been able to measure function before before they start the group and at the end of the group. The group in Burton, they carry on. We've sort of done our bit and walked away. We go back to talk about a topic if we're invited. But generally, we've been able to do a lot of wellbeing activities with that group, and they are now continuing to meet because they like that social interaction. One of the other examples to just pull out from the compassionate community work that we're doing is our computer group. Those of you on Twitter may have met Fred, our 93-year-old, who comes to our computer group. They are a group that, you know, a lot of them, they are older people. They're not all frail. Fred looks quite fit for 93, if I say that in the appropriate use of the phrase. And he was a Twitter sensation. I think it was 5 million people saw his tweet when he celebrated his 93rd birthday, and we encouraged him to put something out on social media. Crafty Pals, I heard from Ian, our community engagement manager, raised over £161 at the Christmas fair at the weekend because they make things and sell them for us. These are groups that come together. They don't need much from us. They need a bit of space. They might buy lunch. But if they want to have a conversation with us about any issues to do with frailty, end of life, advanced care planning, wills, you name it, we'll talk to them about it. But it's very much a partnership with them. This is therefore the model. I know it's quite small, and the small text just keeps growing. I keep thinking, oh, I haven't added that, or we've done that now, and we can add it back on. And as I say, people move through. So of course there's people with long-term conditions. Dementia, MS, I would put in that category. They're palliative, if we take palliative in the extended definition. And they have a longer trajectory. So of course they might dip up to advanced progressive and need some specialist palliative care on an intermittent basis, or become poorly, and they may stay with us or be supported by our community team at home. And equally with comorbidities, of course people who are frail may well also be in those other categories. But it really helped us articulate it internally and to commissioners who we are as an organisation and what we're able to do. So as part of our rebrand, we had to do a why, how, what, which was incredibly painful to figure out some words about who we are and what we do. Simon Sinek, YouTube, I even tried to find some reason to tell the brand agency that there was a better model of doing it. It was that difficult, but I couldn't. So this isn't the one that we're using for our strategy. It's a version that we're looking at for a professional audience, and it's still draft because I'm not quite happy with it. But what we're saying is we are a charity that provides palliative care and bereavement services. We provide support and advice on issues relating to end-of-life care. We work with others to improve end-of-life and palliative care and to promote a compassionate community. You can read it yourselves. We challenge preconceptions of hospice care and transform how people think and talk about dying. And we support people at the end of their lives due to frailty when we're funded to do so. And it's a shame that we've had to put the caveat on the last line, but that is where we are as an organisation. We want to absolutely advocate for all people who need good end-of-life care and access to palliative care services. We absolutely want to challenge, and the fact that our STP has end-of-life as a priority is fantastic. So our work as advocates, as lobbyists, as agitators, going to these meetings and talking to people and trying to look at more cost-effective models is absolutely part of what we do. But when it comes to hands-on care delivery, we have to be able to afford and manage expectations within our society. So to conclude, other than our safety net, we can and would like to grow capacity for frailty, but it has to be funded. And I suppose when it comes to direct care delivery, maybe is the bit that I need to add on to that. Thank you.
Thank you. Thank you, Emma. We've got some time together really to have some reflections, I guess, and some questions, and I'd like to invite you to, there may be something you want to share, there may be something you want others to know, or there may be a question for the audience. We've got Luke, who is wandering around. Thank you, Luke, at the top of the stairs there, wandering around with a roving mic, so please stick your hand up or come to one of the fixed microphones, and please say who you are. But while you're having a reflection, I actually got a question for you, Emma, which is how did you manage the organisational change with people with a different service model?
It was quite interesting because we did, as part of the strategy review, a lot of engagement events. So a lot of listening events, getting people together to talk about if they were in a cafe in 5 years' time talking about St Giles, what would they say, what would it feel like, what would it look like? And we had people that didn't think we should support people with MS because they lived too long. And that was quite shocking to hear from within our own workforce. So we did have to take them on a journey, and actually being able to categorise, define, articulate, talk about, share, debate has been really helpful.
Okay, thank you, Emma. I think we have a lady at number 2. I think that might be Tracy.
We do. Tracy Bleakley, Chief Executive of Hospice UK. I love the idea of the community safety net as a response to frailty, and I hadn't really thought about it like that before, so that's triggered a lot of thinking. But my question actually is about prevention, because I hadn't really thought about frailty as being something that we could prevent before. So is it truly that we can prevent it, or are we delaying it such that people can have a good quality of life for much longer, but accepting there will still be a trigger point at some stage where there will be perhaps a more rapid decline until death?
Sam, do you want to take that first, and then Caroline?
Great question, and I kind of opened it up. I think if we believe that by reversing certain mechanisms which we think will lead to certain changes, then that's prevention of an outcome. Yeah, I think we can. And I think that we've found in other areas that if we intervene earlier, with cachexia, for instance, that we can actually have a better outcome. Now, it's still very much at a kind of exploratory level, but I think the evidence shows that if we can intervene with lifestyle changes, particularly weight loss and exercise, but also other things about, specifically about engaging people in more social activities, because loneliness or being alone is certainly a factor as well. You could say cynically, you're just holding off the day, but for some people that might be significantly enough for them to allow to have a good quality of life until whatever happens, and it may be they'll pop off with a heart attack, as will happen. But I think for those preventable things, we've got to do more to investigate those and put them into action. And kind of programs you're talking about will be a great way of putting those into action. We're talking more and more about different models of research, interventions at the point of care, where we can actually go to the actual setting where the care is being done and even randomize patients there, rather than doing things in a very artificial way as we tend to do in cancer studies. So perhaps we should be collaborating.
Caroline?
I think it's a fascinating question. A huge amount of the frailty work and research from a geriatric perspective is on prevention, and increasingly sort of life course perspectives on frailty. So we now know that people of a particular low birth weight are much more likely to become frail at some point. I guess the question for me is, as a palliative care nurse, clinician, where do I need to be around frailty? So I now, in the service that we work at St Christopher's, we go to a frailty clinic. And what we'll do there is begin to have conversations about ACP, see if there's anything that we can do around symptom control, and then we will withdraw. And then sometimes we'll have people who are referred to us who will refer into the frailty clinic, particularly for functional issues. We're not great at functionality and rehabilitation in palliative care. That geriatric, we've got a huge amount to learn from integrated working around older people's care and physios and OTs. So I think there is that space. It is, however, the case that we will all die in old age. That is not going to change. And I guess for me, the interesting thing about frailty is that it offers us a language to begin to talk about people who have fallen through the gaps because they're just old.
Thank you.
Thank you.
Lady at number 1, please.
Hi, I'm Rebecca Lennon. I'm a palliative medicine trainee doctor, and we haven't really talked much about. It's the first time I've heard a geriatrician really been mentioned, and one of your slides did have geriatrician. I've been really privileged recently in my training to spend some time with the geriatricians purely doing that. And I think my reflections on working with them is that they actually do a lot of palliative medicine and care, just in a slightly different patient population than we're used to, and they do it incredibly well. So I think because I get the feeling from that presentation that we feel the burden is on us, when actually the geriatricians are very skilled in looking after these people and do a lot of what we would do with other groups very well. And I think there are some things that we can definitely offer. But there are also some geriatricians providing incredibly good models of care. So the geriatricians that I worked in base themselves in A&E, preventing hospital admissions. Yeah. And also, actually, in South Manchester, they look after the whole nursing home population. It's not the GPs anymore. So I think there is a lot that we could do integrated, but I think it's together. I don't feel like the hospice that burden's completely on us.
Thank you. I think that's a really well-made point, and what I particularly think is well-made is about the importance of integration and about we are stronger and better and do more together, don't we, than being isolated. I just wondered, Caroline and Emma, whether you wanted to respond to that.
Having been a geriatric nurse, really, for the last 10 years, I would absolutely agree with you. What I would say is that there are very, very good practice, and there's also some very poor practice. One of the wonders of geriatric medicine is that we can keep doing more and more to people. And it's not always easy for geriatricians to know when to stop. So it's really about integrated working and doing much more. It's absolutely, it cannot be about taking this group of people and saying, bring them into us. For me, the challenge and opportunity of Frailty is the exact opposite. It's for us to say, what's the piece that we can do, but we can absolutely do the integration. And just to shout out, the British Geriatric Society are running a conference on March the 6th, which is about the integration of geriatricians, geriatric care and palliative care. And we've got geriatricians and palliative care together to say, how can we support and work with each other? So I absolutely hugely agree. What I think we don't have in geriatric training is end-of-life care. So where people have gone above and beyond. So I know lots of geriatricians who've gone and worked in palliative care because they understand it's really important. But what we're pushing for now in geriatric medicine is that end-of-life care is core, because currently it is not.
I think with shaper training and the way the medical training is changing, I think we've got a real opportunity to actually grasp that. I think we just need to do it.
Thank you. Emma, did you want to say something?
Yeah, I just wanted to add to that from an organisational perspective. So Irene Higginson said this morning that hospices needed to make a decision about dementia. Is it something we should be doing or not, and how can we ignore it because of the prevalence? And I suppose I'm saying Frailty is similar. So it isn't a case of the fact that hospices have to be all in or all out when it comes to frailty. Most of our frailty work actually is happening through community development and not through clinical services. And where it's interacting with clinical services is absolutely through integrated working. And Virgin Healthcare in particular, with the geriatrician in partnership, we're hoping to start to see more rotational training with people interested in geriatrics coming into the hospice and vice versa, because I think there's a lot to learn.
Thank you. I think just with time for the last question over there at number 2, and then number 1, and then we're done.
Hi, I'm Rachel Watson. I'm a medical student from Cardiff University. Firstly, just to say how interesting I found it. I think as a medical student, we all feel are increasingly comfortable throughout our training with more clear-cut diagnoses of different diseases, and things like frailty sometimes aren't focused on as much because we're not there's not a particular history for a particular exam. So just to say how interesting I found that. But just a question, the professor, about the biomarkers in frailty and in the research. One of your slides said that patients with frailty have some of the highest numbers of other medical conditions. So when you're researching something such as frailty, how big a proportion of sort of the frailty population just have frailty? I can't imagine there's that many people that have frailty that don't also have comorbidities and other things that they'll have biomarkers for in that area.
That's a really good insight, and you're absolutely right. There is no kind of threshold over which you have to pass to be declared frail the day before you weren't. And people who ending up in that frailty pathway probably pick up several conditions. So they fit very well with the multimorbidity concept. And the kind of conditions we're talking about are, one by one organ failures, also the kind of things that we do during cancer treatment, for instance, so that we know that when you give high-dose chemotherapy, many of the patients will end up with low levels of testosterone, of other hormones as well. They didn't have that. We've given that to them, as well as the other conditions they had as well. So it is very much a multimorbid condition. Not everybody with multimorbidity ends up frail. So it's something special about people who end up frail as well. Maybe they're just tipped over certain thresholds, and maybe that's where the biomarker work might help us to say, well, can we prevent people going over that threshold?
Thank you. And then finally,
can I just say something, which is, I think you are our future. Because we have spent too long extracting people into single disease and that doesn't work. The reason that we don't have a huge amount of evidence is that random controlled trials until recently have actually deliberately screened out multiple morbidity because it's too confusing and too difficult. We have at every level to find a new way of thinking and working and evidencing, and I am so pleased to hear your question, and keep going.
And just to embarrass Rachel, I think you've got a really good poster as well, haven't you?
Yes,
on transition, from one end of the spectrum to the other. And finally, and thank you for your patience.
I'm not going to get anybody to answer this because it's probably going to be too long. I'm Hayley Carr. I'm a non-clinician, so bear with me. And somebody that everybody in my family's always been 2 pound underweight, and nobody yet is frail, so hanging in there. The question for me is what we do also, not just at hospices. This is a societal issue, because the majority of people, I worked and lived in Japan and Germany, and the depression rates are half hours because people look after the elderly. And whether it's frail or elderly, the biggest thing they focus on there is the number of people around you, your family and friends. And they suffer, I think the figure I saw last week, something like 36% less issues for emotional stability for elderly people. So it's just a thought that it's not just hospice. We should be feeding upwards and outwards, guys, and educating everybody else, not taking it on ourselves.
So useful to hear that. And I suppose that's what I want to capture again about the vision and the edginess of hospice, to be the people. One of the wonderful things about not getting huge amounts of NHS funding is that it gives you the ability to push and to say, this is what we should be doing, this is where we should be going. And it's really, really not about hospice being the answer. But what we can also be is a critical friend to society about dependency, about aging, about loneliness, and all of those things that are absolutely key to good quality of life and quality of dying. So, yes, absolutely.
So on that note, I'd like to thank all of you in the audience and all of those who've commented and questioned, and also to Caroline, Sam and Emma. And I'm going to read this because I want to get this right. So this is what I wanted to say to you, is thank you for your generosity of thinking and experience, combining the art of humanity with the science of knowledge to make a difference for those living and dying with frailty. So thank you very much.